ma'am, and it is an absolute pleasure to be part of this wonderful symposium, mainly because I feel that it is the right time to have this as an important aspect in childhood blindness. And I would be presenting some of them will be repetitions. This is all repetitions. I will skip those slides. We have discussed this at length. All this has been discussed. Just a small point that near work outdoor exposures and myopia in children is now a very well-known accepted fact that there is a close association between near work and myopia. And so these are some of the things. And so I would be showing some of the work which we have done. And because in prior practice we don't have huge numbers, I would really love to see bigger studies in these groups. And so this was a study in which we did on pre-myopes, and the future is obviously to start thinking about stopping the progression in pre-myopes, because that would be the next go-to goal of all of us, to prevent the progression and to try to reduce it before it actually becomes a menace. So this was a not a very big number, but we tried to compare two groups: children who were suggested to use atropine and did not use it, and children who we could convince them and they started using low concentration atropine. We found that so these pre-myopes were basically children who were already on follow-up with us and were either small hypermetropes, 0.5 diopter, spherical, and then went into becoming myopes or became emetrope. And we started measuring axial lengths almost 6 to 8 years back. Since we started using low concentration atropine, we made it a point to start measuring axial length in the susceptible group, and we found that this was quite an interesting thing, that you can start them quite early when you have sufficient data to suggest that they would be progressing. So that is one thing. This is just from the data which has already been published. I entirely enjoy sharing this particular publications from Andres on the risk factors. This is I discuss it a lot. This all we have discussed, and so we will. This is an important slide because I think there was a wonderful talk by Dr. Nina on the comparison of lamp and atom. I think that atom study, atom 2 especially, clearly said that it was a concentration dependent response, although lamp study mentioned that atom 2 did not suggest that. Atom 2 clearly suggests that it was indeed a dose dependent response, just that the results were not significantly different. Optimal concentration is what the future holds. We don't know what is the optimal concentration, despite lamp 2 study suggesting that 0.05% is a wonderful concentration. We don't know whether 0.06 will be better than 0.05 or not. So this is this is like 0.05 has been halved to 0.025, which has been halved to 0.01 and compared. So there is no clinical or rather there is no scientific thought process that as to how they came to this conclusion. Why they came to this conclusion? Because they have doubled it and used it, which is a wonderful thing, because now we know that 0.05 works better than 0.01. But the whole problem here is that we don't have a biomarker. We don't have a biomarker which can simply tell us quickly that this particular drop is working, and in a short period of time. All our work, we have to wait for a year, 2 years washout period. So it takes a couple of years before we are sure that this particular thing is working. Where does all this leads us to? All this leads us to the fact that atropine eye drops do reduce the progression of myopia. Whether we should give it in pre-myopes or not, we still have to wait. Whether it is which concentration would be wonderful. To begin with 0.01%, but would increase in concentration in non-responders, would they respond? We don't know. Whether they would respond to twice a day, some of them may respond. How much would be the compliance? This is our own study where we found that almost 14% did not comply. Again, very small sample size. This was for pre-myopes, which I already shared. This was a study which we started doing when LAMP 1 came, and we tried to find out whether single versus twice a day would be better or not. Twice a day indeed is better than once a day, with no significant increase in side effects. And whether non-responders, whether we can increase the BID dosage, and we found that almost 30% of children did respond to increasing the frequency, but almost 70% still did not respond. Now we have started them on 0.05%. We are still waiting whether they would respond or not. And so this is another work where we were already having patients who were not using atropine and progressing slowly since 2018-2019, and we found that there was a huge jump in their average growth and even in their myopia, especially during lockdown period. And this is what Sumita Madam was saying. We had our own small work where we found that it is indeed useful, and I think we are those anecdotal experiences. We have just 7 patients where we found that we tried to use low concentration atropine, and this was in 2019 when we looked into the data of those 7 children. It works for pseudophakic children as well. And what are the future areas of research? Tremendous. So first and foremost is whether there can be other drugs. So way back in 2012 or 13, there was a paper from Denmark where they have studied the usage of 7-methylxanthine. Unfortunately, it is not available in India, and so they have done a 2-year study and found that 7-methylxanthine was indeed a good drug, and that also retarded the progression. We are in search of biomarkers, dopamine being one of them. Whether there are any other biomarkers which can help us find out quickly which particular patient would be responding to low concentration atropine, and whether the increase and decrease in that particular biomarker would be able to tell us that this patient is having a good effect of atropine or any other drug for that matter. Concentrations are at large. I mean, there is 0.01, 0.02, 0.05, and we will be seeing more and more work in permutation and combinations. Till that time, we have got 0.01% at this point of time in India. Now it is DGCI approved, so good for us, but we will have to hold our breath there. Other interventions, there are plenty of different type of aspheric glasses which came 5 years back, and another one came with a theory of myopic defocus, hyperopic defocus, and myosmart glasses are there. Highly aspheric lenslet target designs are there. I have not used both of them, and so I have no idea. But yes, future does hold promise there. Modified schools, whether we can, if at all, I would like to take this opportunity of this forum and like to ask for a national program for prevention of myopia progression. And if that happens, there could be modified schools, modified education system that holds the future, because if at all, if the progression is going to be 40 to 50% incidence, then we need to think of it at this point of time. Physical infrastructure changes, lifestyle modifications, which have been aptly discussed, and whether those modifications can be incorporated in the sensitive time and sensitive period of children, whether we can go back to Gurukul training, or whether we can the walls of the class, and every 20 minutes we can takes a lot of time to understand whether this particular intervention is working or not. So I will come back to the most important thing which is in demand is search for biomarkers which we need quickly, so that we can do more and more work and quantify whether this particular intervention is indeed working or not. So thank you so much for giving me the opportunity to speak on this particular talk. Thank you so much.